Good evening, everybody, and welcome to tonight's Facebook Live, where we're going to be talking about breast cancer and, in particular, treatment options now available for breast cancer and the potential side effects of treatment. My name is Ian Irving. I'm ICON's Chief Medical Officer, and I'm also a practicing haematologist at ICON Wesley. But tonight, talking about breast cancer, which thankfully has shown incredible breakthroughs over the last number of years, and certainly survival for patients unfortunately diagnosed with breast cancer is much better now than it was decades ago. And tonight, to talk about breast cancer, we have two breast cancer experts. Firstly, Dr. Louise Knott. Louise is ICON's Director of Medical Oncology. She's a very experienced medical oncologist with special expertise in breast cancer. She's been principal investigator on numerous clinical trials, and as well as setting up ICON Hobart, Louise also works as a medical oncologist at Royal Hope tonight. Dominic Lunn. Now, Dr. Lunn is an interest and particular expertise, including research publications in the radiation treatment of breast cancer. Dom currently works at ICON Cancer Centre's Auchenflower, Redlands, and Greenslopes, but previously, for over a decade, Gold Coast University Hospital, where ICON Cancer Care provides radiation treatment to the patients of the Gold Coast University Hospital. So, Dom, thank you for your time tonight and welcome.
Thanks, Ian. Hi, everyone.
So, breast cancer, as we all know, is not an uncommon disease, unfortunately. Thankfully, you take up screening for breast cancer. So we might just start right at the very beginning, and if I could throw to you, Lou, to describe what happens when someone finds a lump in their breast. How does the diagnostic and then treatment journey start off?
Yeah, thanks, Ian. And I think you're right. There are two main ways that women might present with breast cancer. So firstly, it might be asymptomatic, so have no symptoms and they're just going along for their screening, and they are identified to have an abnormality, which then leads to further investigations and a recall. Or alternatively, a patient might actually notice changes within their breast, obviously a male or female, and that might be a lump or a change in contour, change in nipple or discharge, or some sort of change in their breast that leads them to see their local doctor and that might be a screening mammogram, or it might be a mammogram and ultrasound, for example, through a diagnostic imaging service if they have a breast symptom. And then if there is an abnormality identified, obviously the patient would have an explanation from the doctor and be offered a biopsy of that area. And that might be a biopsy of a lesion within the breast, or, for example, if there are some abnormal lymph nodes underneath the arm or the axilla, they may also be biopsied. Confirms a diagnosis of breast cancer would be the breast surgeon, who might organise additional imaging, so sometimes an MRI scan or a different kind of mammogram. And once they have all of the information about the type of breast cancer and some local staging, usually the patient's case with their consent would be discussed in what's called a multidisciplinary meeting, where we have best treatment from there on in. And that might take a number of forms. So in some types of breast cancer, we might look at giving some systemic treatment, or that's things like chemotherapy, immune therapy, targeted therapy before the surgery, and that's called neoadjuvant therapy. And sometimes we give that after the surgery. That's adjuvant therapy. But essentially that treatment plan is made, and then the patient is referred to the various specialists to undertake their journey. And I guess in the vast majority of them, the case will be rediscussed at the meeting with that pathology, and we'll then determine the best treatment algorithms moving forward. And obviously that could include radiation and the various types of systemic therapies that we have for our breast cancer patients. And in amongst that, we'll of course be talking to patients, about potential genetic testing if that's appropriate, things like PET scans or CT scans and bone scans. If they have involvement of the lymph nodes, for example, or there are other higher risk features.
Right. No, thank you. Well, it's very comprehensive. And you mentioned there that, surgery is still a very important part of the treatment of breast cancer. And I guess surgery could either be a mastectomy or a lumpectomy. I think you did mention often with a lumpectomy, radiation is done afterwards. Breast reconstructive surgery, of course, can be done early or late, and it's probably a topic we won't really touch on tonight. But can you maybe run us through, Dom, now, when would a lady or a man, but more of cancer, and how has that changed what type of surgery is performed?
Sure, thanks, Ian. Look, I think it's probably worth just quickly touching on the sort of historical aspects of how breast cancer has been managed surgically. And certainly, in the early days of breast surgery, standard surgery was once what we called a radical mastectomy, where the entire breast was removed and sometimes some of the underlying muscle. And standardly, all of the lymph glands that sit in the underarm area or the axilla were removed with what was called an axillary dissection. And whilst this wasn't a bad cancer treatment, it was a particularly morbid procedure for women. Obviously left them without a breast and often had lots of ongoing side effects related to such major surgery, including things like lymphedema, which we talk about, which really relates to sort of swelling of a person. Really, studies that sort of were done back in the 1970s and 80s, it was shown that actually by doing what we now call breast conservation, in other words, just removing the lump in the breast, but then targeting the breast tissue with radiation, outcomes were actually equivalent between those two procedures. And so over the years, we've really evolved into an era which I would call breast conservation predominantly. And I would say to most of my patients, it's really a package deal that if you've kept your breast, you're going to be offered radiation as part of that overall management. And they should be reassured that from a cancer point of view or an oncologic point of view, that their outcomes are actually no different between those two. So they have some benefit. As well as having much less these days, this surgery in that underarm or axillary area is also much reduced. And most women would undergo something called a sentinel node biopsy, where rather than taking all the lymph glands sort of en bloc, a special dye is used to try and track the same pathway where cancer cells might spread. And those sentinel lymph nodes are identified. And if they're clear, then thankfully those ladies don't need any more surgery. And in fact, even in the case where sometimes one or two of those lymph glands are involved, we know that we can actually give radiation to that area and similarly have just as good outcomes as bigger surgery, but with far less side effects. And so the majority of patients that I see who are treated with radiotherapy would be those women with early stage breast cancer who have kept their breast. that being said, there are still a proportion of women whom for whatever reason may have a mastectomy if they're unsuitable for breast conservation due to features of their cancer, or they've made a personal choice. And a small proportion of those who are very high risk would also benefit from what we call post-mastectomy radiotherapy, or radiation after a mastectomy.
Okay, no, that's been very informative. Thank you, Dom. And certainly to everyone watching, if you have any questions, please enter them through the live chat. We're going to hear from both Louise and Dom for the first half of tonight's talk, but then in the last 20 minutes or so, we'll go to your questions and we'll explore really whatever topics that you want to hear about with respect to breast cancer. So please, as you're listening, don't hesitate to put through some questions for our two breast cancer experts tonight. Just following up on what you mentioned, Dom, about early stage breast cancer, where there has been breast conservation surgery and a lumpectomy, and then the patient will undergo breast radiation therapy. Could you just outline for us what that actually entails? How has breast radiotherapy evolved over the years, and what side effects might occur during the treatment?
Sure. Look, just in very broad terms, radiation therapy essentially involves targeting parts of people's anatomy where there is a potential for risk of microscopic cancer. And these high energy X-ray beams that we focus to that part of their body has the ability to damage and kill cancer cells. And that's essentially why we use radiation. The reason that radiotherapy is a good treatment for cancer really hinges on the fact that cancer cells are much more susceptible to damage from radiation therapy than the normal cells in the body, and that the normal cells in the body also have the ability to repair any damage, whereas the cancer cells have lost that ability. And so radiation therapy exploits that sort of innate difference in the way that cancer cells and normal cells respond to these high energy X-ray beams. Now, radiation therapy is actually a very old treatment, and I once saw a painting of apparently the very first radiation treatment, which was performed in 1896. Everyone in the room was wearing a top hat, which we don't tend to do so much anymore. But it's been around for a long time, but it's vastly changed, really related to how technology has evolved. And that involves things like computing ability, but also medical imaging and our ability to really pinpoint parts of the body with very focused radiation. Now, that's important because a lot of the toxicity or side effects of radiotherapy largely results in parts of the body outside of, say, in this case, the breast, receiving some doses of radiation, and that can lead to, commonly what we see as side effects. Within the last sort of a large dose of radiation in one or over many days, and previously we used to treat over 25 to 30 individual doses that we call fractions, and that was based on a Monday to Friday schedule, and so people would have to come with a course on the back of lots of big international trials. We know that we can actually deliver that radiation in a much shorter time, and standardly now and there's more emerging data that in certain situations we can actually treat in just 5 treatments over. Much better from the patient. The toxicity tends to be much less than it once was. In terms of what people tend to experience on a day-to-day basis, their own experience is much like having an X-ray every day. And the treatment involved in setting some of the normal side effects that I would explain to my patient. A lot of cancer treatments, and radiation is no different. Treatment and for some weeks following, but that then tends to recover. That being said, we have lots of patients that work full-time during the course of their treatment and cope very well. One of the other main side effects that people tend to experience is how the radiation can affect the skin. And that's really the skin over the breast area or the underarm area where they're receiving that treatment. Some women get very little toxicity and their breasts may go a little bit pink and then recover. However, a small proportion of people can still get quite marked skin changes and can go quite red and even get some peeling, a little bit akin to a sunburn. But similar to any sort of other skin damage, it tends to be self-limiting and just resolve by itself. And our very experienced nursing team, will give education sessions on types of moisturisers and skincare that are appropriate for those patients. But certainly when we treat over the shorter courses, that skin toxicity is far less than what we once experienced.
Right. No, thank you, Dom. And you raise a very good point there about nursing staff being absolutely integral to cancer care. Louise had mentioned that before, that a multidisciplinary approach to cancer treatment is what is needed, and certainly our nursing colleagues, both in radiation medicine and across medical oncology, do a fantastic job in caring for patients. So that was a very good explanation about radiation therapy. That's often not the end of the breast cancer journey and treatment. And then after radiation is finished, adjuvant treatment is often needed. And I know there's a whole myriad of adjuvant treatments, and you've probably got a bigger list of treatments to talk about here, Lou, but I'd like to pass over to you, and I'm sure the listeners are interested in you going over the types of adjuvant treatment for an early stage breast cancer, which has been treated with lumpectomy and breast radiation. What sort of treatments are then given by medical oncologists like yourself?
Yeah, thanks, Ian. And you're right, there are multiple treatments that are available for women with early stage breast cancer. And we can really personalise the treatment these days because breast cancer isn't just one disease. It has many different phenotypes, as we call them. And that's how we kind of determine the type of treatment that is best suited to the patient. So we do break it into kind of treatment before the surgery and then treatment after the surgery, so the neoadjuvant versus adjuvant. And generally, in most cases, our treatments do go before the radiation unless it's endocrine therapy. So we tend to give our systemic treatments like chemotherapy and some of the targeted therapies either before the radiation, sometimes with the radiation. But the way that I think about it is that I think about the type of breast cancer that the patient has. So, for example, if a patient has a triple negative breast cancer or a HER2 positive breast cancer, which tend to be the cancers that are a little bit more aggressive, the cancers that we would consider for treatment before surgery, particularly if their tumours are slightly larger, so 2 centimetres or more, for example, or lymph node positive, so to benefit from having a contrast sometimes with other anti-HER2 therapies. And we give a course of treatment actually before the surgery. And we know in that case that sometimes about half of the patients that we treat might actually have no residual cancer after their surgery. So they have their surgery, then the pathologist looks at the specimen, and in fact, there's nothing that can be seen. And, that's really important because that helps us determine what treatments we then give after the surgery, but also helps us determine a patient's prognosis. And I think, might help us tailor some of the other therapies that come after surgery as well. In the case of triple-negative breast cancer, there's been lots of work done in recent years to improve outcomes of this fairly aggressive type of breast cancer. And thankfully, we are making grounds and seeing advancements and improvements in outcomes. So for women with early stage triple-negative breast cancer that is 2 centimetres or greater in size and has positive lymph nodes, we are able in Australia to consider immune therapy, so an immune checkpoint inhibitor, so a drug called pembrolizumab that we give with chemotherapy, once again before the surgery, so neoadjuvant treatment. And similarly, we expect, roughly half of our patients to have no residual disease after the surgery's been done when we look at it down the microscope. So that's very different to how we would treat, for example, a patient with estrogen positive breast cancer that is not HER2 positive. Those sorts of patients with estrogen positive, progesterone positive breast cancer, we call them luminal cancers. Most of those patients would go and have their surgery first. Very occasionally we might give chemotherapy beforehand, but mostly they would have their surgery first, and then we would look at the pathology. And for patients that have higher risk disease, so that might be, for example, a high grade of the cancer, so it looks more aggressive under the microscope, or there's involvement of the lymph nodes, those patients might be offered some adjuvant chemotherapy. And then once that's completed, we would then move on to the radiation. And for the patients with estrogen positive breast cancer, we use endocrine therapy. So essentially what that means is there are various treatments that reduce the estrogen or the effects of estrogen, I guess, on the receptor, in the estrogen receptor, which is what is causing the growth of the cancer cells, or at least one of the growth factors in these cancer cells that are estrogen positive cancer cells. And they're usually, for most patients, tablet therapies. There are 2 main classes we think of. So there are aromatase inhibitors, which we generally use for patients who are post-menopausal, gone through menopause, or we have given them other treatments to make them menopausal, because those drugs only work when the ovaries are not functioning. And we have tamoxifen, which has been around for a very long time, also an excellent drug. And we can use tamoxifen in women, younger women, premenopausal women, and in postmenopausal women. And in general, those sorts of drugs are continued for 5 years, if possible. And sometimes we do a mixture of them. We might do an aromatase inhibitor for a certain number of years, and then tamoxifen, or vice versa, or all of an aromatase inhibitor for the 5 years. And then in some women who have higher risk disease, we might continue the endocrine therapy even a little longer than that, so maybe 7 years, sometimes longer. There are other treatments, new kids on the block as well, I guess.
Mm-hmm.
So we have a class of drugs called CDK4/6 inhibitors, abemaciclib, which is a fancy new oral therapy which essentially stops the cancer cells from kind of dividing. And we use those oral drugs in women with high risk estrogen positive breast cancer in combination with their endocrine therapy. And those drugs go for 2 years, and they've also been shown to reduce the risk of relapse and improve the outcomes for women with estrogen positive breast cancer. And I guess then finally we have olaparib, a PARP inhibitor, another very cleverly designed drug, which is very useful for patients who have specific kinds of mutations, germline mutations they were born with, that increase their risk of breast cancer and ovarian cancer. And these patients are often screened with a blood test to determine whether or not they have one of those mutations. And women at who had developed a breast cancer, who have one of these mutations, particularly if it's a higher risk breast cancer, may be offered this tablet drug called olaparib for 12 months after their surgery. So lots of new drugs available, all have been shown to improve outcomes for women with breast cancer. And they obviously all have various side effects, and I'm happy to focus in on some of those, particularly if there are questions from the audience that they might be interested in.
Yes. No, I think that excellent. Thank you for that answer, Louise. And certainly it's a very complicated business, and as you've pointed out, depends on the type of breast cancer as to whether the patient will receive neoadjuvant chemotherapy and then go on to their surgery and radiation therapy, or whether they're going to receive adjuvant chemotherapy, which is after the surgery, or whether hormonal therapy plus or minus some of these newer drugs are used. It's very complicated, and you've given us a very clear explanation. Just going into the side effects of each treatment, maybe focusing first on the side effects of the neoadjuvant chemotherapy, and then of the hormones, and then maybe with your questions through the chat, we can go on to the newer drugs. But
yeah. So perhaps I think a lot of people might be familiar with some of the side of, for cancer in medical oncology for a long time, and often it's the bit of the treatment that people dread the most. They're worried about the side effects, but I guess thankfully we have improved in the way that we can support patients with the side effects from chemotherapy. Our drugs are so much better in reducing many of the side effects associated with these drugs. Therapy rapidly divides. Other cells in the body can be temporarily affected by chemotherapy. So things like your gut lining cells, so people worry about some nausea. There can be altered bowel habits, those sorts of things, fatigue, hair loss. People worry about effects on the bone marrow, so reduction in your immune function for a short period of time. Very occasionally, patients might become mildly anemic. Very, very occasionally would we ever have to give a transfusion of blood or anything like that. With regards to the I guess the medications that help mitigate some of the side effects. We've got very good anti-nausea medicines. We usually use a combination of different anti-nausea medicines, and mostly I have to say, thankfully, our patient nausea with these regimens. I certainly remember as a regimen, we used to have to put them on things called syringe drivers. These are saying it's not there to reduce the whites in therapy will often be used, or low neutrophils, which can increase the risk of infection. And once again, thankfully, as a result of using these medications, we very rarely see patients come into hospital with fevers and really severe infections. Although it's still a possibility, it doesn't happen very often these days. Many patients worry about hair loss, and that's totally understandable. I guess it's that outward kind of, people know that you're going through chemotherapy. So we often use scalp cooling for many of our regimens. It's not always effective for some of our regimens, but for some of the more commonly used regimens, it is effective. So about 80% of patients will be able to keep their hair with the regimens such as docetaxel and cyclophosphamide, or weekly paclitaxel, those sorts of regimens. And that's a cold cap on your head, which essentially reduces blood flow by essentially freezing the scalp, I guess, and it stops the chemotherapy being delivered to the hair follicles and reduces hair fall. It also enables patients to have their hair grow back more quickly and reduces patchy hair loss. So that's really important. In terms of other supportive measures, sometimes our drugs can cause what's called peripheral neuropathy, so you can get pins and needles in your fingers and toes. There are ways that we can obviously monitor for this and adjust doses. Some centres are using cold gloves, other centres are using double gloving, or just really close monitoring. So lots of things that we can do there. We give patients a lot of education about managing their bowels, those sorts of things. Fatigue is also important. Continuing to exercise throughout treatment is incredibly important. It reduces fatigue. And then there are other specific side effects of the chemotherapy drugs we use. So sometimes we have to monitor for heart function by doing what's called an echocardiogram, just to make sure there's no adverse effects on the heart. But, most of these side effects are manageable, and with the help, as Ian said, of our multidisciplinary team, our nurses are fantastic, a great, bank of information they have, and they will sit with our patients in the day hospital whilst they're having their infusions, because they could be there for several hours, and they go through all of the potential side effects, what to do about it, and the patients have numbers that they can call and hopefully feel pretty supported throughout the process. And so those side effects are usually whilst you're on the treatment. Obviously, there can be some fatigue, and there might be some, residual effects of chemotherapy that go on a little bit beyond that. But generally, it's, short, sharp, then it's over and you're recovering. With regards to things like endocrine therapy, so they're the anti-estrogen therapies, those treatments are more ongoing. So whilst the side effects perhaps aren't as severe, they are more kind of lower grade ongoing side effects. So it's really important we manage them. The main side effects that patients complain about on endocrine therapy, rightly so, because sometimes they can be extremely annoying. Things like hot flushes, I know all about those at the moment, so I can empathise with my patients now. So hot flushes can occur whether you're menopausal or not. Anti-estrogen therapies will cause quite severe hot flushes in some women, and we have many treatments to try and reduce that. And that might be medications, it might be lifestyle factors, sometimes acupuncture, all sorts of things we can do to help support patients who are experiencing that. Other side effects can be effects on sexual function, vulvovaginal dryness. You can get things like thinning of your bones that we need to monitor for. Once again, aches and pains in the joints, so keeping people physically active is extremely important. And several other potential side effects. And I think with the endocrine therapy, this is where we really have to make sure we're seeing our patients, encouraging them to stay on the treatment, and doing our very best to try and help them work through those side effects, most of which do improve over time and become more manageable. So I think that they're the two main, with chemotherapy and endocrine therapy. There's obviously other treatments involved with their own sets of side effects that perhaps is beyond tonight's discussion. Unless there's specific questions, I'm happy to go through.
No, thank you, Louise. Very comprehensive. And as you say, thankfully, treatment is not as arduous as it once was, and most people can get through chemotherapy with far, far fewer side effects than they did decades ago. Going back to you now, Dom, you went through the side effects of radiation therapy whilst people are having radiation therapy. There's been a couple of questions come in asking about radiation therapy and can you use zinc on the breast after radiation to the breast as a first question. But then secondly, perhaps you could outline for us some of the, if there are any, longer-term side effects of radiation on the breast, and particularly, does radiation have any effect on bone health in the long term?
Sure, thanks, Ian. With regards to the skincare related to that first question, so certainly, there are a proportion of women whom they might get some skin blistering or peeling, and there are various options that you can use to try and sort of expedite healing, one of which, is a zinc-based cream, and absolutely you can use that after radiotherapy. I silver-based cream, which was cream that helps with that also. Historically, some of these metal-based creams we've avoided during the treatment of radiotherapy, more for theoretical reasons that sometimes that cream on the layer of the skin can actually increase the radiation dose during the treatment. So some of these creams we don't recommend until after treatment is finished, but absolutely once treatment is finished, yes, you can use those sorts of creams. And again, most of our treatment centres have very experienced nursing staff who quite often have their favourite little recipes that might be tried and tested for their patients, and that might actually vary a little bit between the different sites, and people have their own opinions, but there's a lot of different options. I think your next question, side effects of radiotherapy, and certainly, whilst radiotherapy is tolerated very well in the short term, there can be some ongoing issues. We often think about the ongoing cosmetic effect, and obviously I say to my patients, there's no point saving the breast if we're obviously then going to make it look funny sort of moving forward. And the tissue in the breast that's been treated over time does tend to feel firmer and thicker than the breast tissue on the other side. And patients themselves will be aware of that, even if cosmetically, from an observer's point of view, there's not much difference. But over time, that tissue thickening can cause some size and shape asymmetry between that breast and the untreated breast. But by and large, most women are very happy with their cosmetic outcome. Occasionally, particularly women with larger breasts can develop a lymphedema in the breast itself. So the breast itself can develop some fluid accumulation that can result in a sort of heavy or sometimes a red breast, and we tend to treat that with massage or more compressive style bras. But that would sort of be a minority of patients these days. Related to the bone health question, I could see one question came up and said, does it affect osteoarthritis? And the answer would be no for that. And in fact, a lot of countries use low doses of radiotherapy to treat osteoarthritis. Osteoporosis, and does it impact the integrity of the bones long term? And the answer is potentially. Certainly, I think in my career, I've seen maybe one patient who I thought after their radiotherapy had developed a rib fracture that was, I couldn't have an air event. And generally speaking, the integrity of the bone is not largely impacted by the doses of radiotherapy that you would receive with breast radiation.
Okay, no, thank you, Dom. That is good news. Louise has explained to us how chemotherapy has really changed over time. There are so many more drugs available and medications that we use to treat cancer now. In radiation, could you give us a bit of a flavour for some of the sort of modern day techniques that are applied to radiation therapy for the breast, and in particular maybe referencing the Identify trial that
Sure.
some of our listeners and people watching may have heard of?
Yeah, sure. So the one-off appointment that we call planning or simulation, and that involves us doing a CT scan of the patient, which is like a three-dimensional X-ray, and we get pictures of the patient and their anatomy, a bit like we've sliced them up and it's those pictures that we then involves us on all of those in this, find that very accurately. But we can also define the other structures inside the body very accurately. And as our technology has increased over the years, we're pretty sophisticated in the way that we can focus those radiation beams to the other structures that are close by, particularly on the left side, would involve the heart, but also the lungs. Now, we know that with very old-fashioned radiotherapy, whilst was very effective, the delivery was much more unsophisticated and less focused, and some of the heart tissue would often receive the same dose that the breast was receiving. And we know that that had an impact on people's long-term cardiac health. These days, thankfully, that is not the case, and the risk of long or ongoing cardiac trouble from radiotherapy is really quite minimal. One of the techniques we use is called deep inspiratory breath hold, or DIBH for short. And it's a very simple maneuver where at the time of someone's planning and then at each of their daily treatments, we get them to hold their breath. And doing that very simple maneuver, when you take a big breath in and your diaphragm moves down, the position of the heart changes in such a way that it moves down and forward, really moving away from where that radiation dose is focused on the breast, therefore reducing dose to the heart and therefore the risk of long-term toxicity. Focusing particularly on the technology you mentioned, Identify is a technology produced by Varian, which is one of the big manufacturers of radiation treatment machines, and it's essentially a form of what we call surface guidance. Now, once upon a time, the way that we tried to estimate a patient's position was to use tattoos. So standard ink tattoos, little dots on the skin, and we use that as a reference point each day in where the patient was in relation to the machine. These days, these surface guidance technologies allow mapping out the whole contour of a patient with what we call stereo vision cameras. And I noticed in some of the Olympic events I've been watching, every now and then they'll freeze frame an event and sort of rotate around that athlete as they're in the middle of doing something amazing. It's quite similar technology, actually. And so the body's, the patient's contour is mapped, and then each day can be reconstituted, and we can see where that patient is in space related to where we want them to be, and that's great. Deliver treatments to them and avoid available, reminding them of their treatment. Quite remarkable, even in time, which is
fantastic. Thank you, Dom. And yes, you make a great point there. I mean, watching the Olympics or any sport on TV is very different now than it was decades ago, and that's a very good explanation. Thank you. We're in our last few minutes now. First of all, to everyone tuning in, thank you very much for watching. For those of you who may have missed the event live, the Facebook Live recording will be up on our website, and certainly feel free to share it with colleagues and friends and family members, because certainly both of tonight's speakers have been so informative regarding breast cancer. As we close, I'm just going to throw a few quick-fire questions at you, Louise, just for rapid answers to go over some of the questions that our audience have put, just one by one. So, firstly, if you could give us your very quick summary of what is lobular breast cancer.
Yeah, so lobular breast cancer is the rarer of the breast cancer, still about 15% or so of patients. It's often harder to detect. And I think the question is there any research on lobular breast cancer? Yes, there is. There was a big dedicated session last year in San Antonio on breast cancer, especially looking at the genomics of lobular breast cancer, new therapies, etc. Lobular breast cancer tends to kind of metastasize if it's going to unusual places like the gastrointestinal tract. But it is a cancer that a lot more work's been put into. So I was just hoping to get that message across to whoever asked that question.
Right. What about the question that came in? You mentioned for example, estrogen receptor positive breast cancer, hormonal treatments are often taken by women, often for a prolonged period of time. There was a question that came in asking that if someone has had their ovaries removed, is it still necessary to use that hormone blockade with tamoxifen or aromatase inhibitors?
Yeah, that's also a really good question. And I think the answer is in many cases it is. So a combination of having your ovaries out or doing something to stop the ovaries from working, plus either tamoxifen or an aromatase inhibitor is better than just having the ovaries out alone. Now, there are obviously nuances to that depending on how high risk the breast cancer is, but there are several circumstances, particularly in younger women, particularly in women with high risk breast cancer, where we do talk about that combination of therapy. So yeah, there are cases, definitely.
Fantastic. Thank you. Very clear. And final question for the evening, Louise. Metastatic breast cancer, metastatic meaning when a cancer has returned and spread to distant organs. So obviously we've tried to focus tonight on the treatment of early breast cancer, both systemic treatment and radiation therapy. But if we look into metastatic breast cancer, the unfortunate situation where the cancer has returned and spread to other organs, do you just want to give the audience maybe a taste of one or two of your drugs that have come up in the last year, maybe two of the sort of hot topics around at conferences where there have been game-changing treatments for metastatic disease? Because I know obviously there are lots of different treatments that are given for metastatic disease, but your top two new treatments for metastatic disease.
I think the big game changers that I've seen are, so in estrogen positive breast cancer that's metastasized somewhere else in the body. These days, most women do not have chemotherapy as their first line treatments. That's a big change from when I started. So most women will receive a combination of this oral drug, the CDK4/6 inhibitor we talked about before, and we've got 3 of those on the PBS in Australia to choose from, in combination with another endocrine therapy such as an aromatase inhibitor, for example. So most women will have tablet therapy with advanced estrogen positive breast cancer, hopefully for many years. That's what we hope, and not have to have chemotherapy for some time. So it's been a big game changer. And I guess the other big game changer are these drug antibody conjugates, where they have a fancy, fancy antibody drug with a chemotherapy attached to it. And these drugs are used in HER2 positive breast cancer. So a drug called trastuzumab deruxtecan, which has really, improved outcomes for women with HER2 positive breast cancer. And also another one in triple negative breast cancer, so sacituzumab govitecan. So a whole new class of drugs, which has also just come about over recent years. So fantastic new things coming for patients with advanced breast cancer as well.
Oh, thank you, Louise. That's a great way to finish tonight's talk. And the myriad of treatments is dizzying sometimes, and it is very hard to keep up. And that is why we put on these Facebook Live events for people to watch, because the amount of information on the internet for talking about cancer treatments is very large. It can be very difficult sometimes to find your way through that forest of information. And so we're very indebted to Dr. Dom Long and Dr. Louise Knott, for being our breast cancer experts tonight and guiding us through the treatment of breast cancer with a particular focus on early stage breast cancer. A big thank you, Dom and Lou, for giving up your time tonight. Thank you also. Thank you also to everyone watching. As I mentioned earlier, tonight's recording will be on our website together with a transcript of the questions with some abbreviated answers to the questions that you've put forward. Once again, thank you to everyone.